Welcome to the latest edition of the Mind-Gut Conversation, the interview series about topics related to health of the gut, the brain, and the environment. Today, I have the pleasure to talk to Professor Felice Jacka, who is the director of Deakin University's Food and Mood Center and founder and president of the International Society for Nutritional Psychiatry Research. Dr. Jacka is an international known expert on the role of nutrition in mental health and has led studies confirming the benefits of dietary improvement on depression. Dr. Jacka is also the author of a new book called Brain Changer, The Good Mental Health Diet, the latest cutting-edge science on how diet can affect your risk of anxiety and depression and influence the health of your brain. Welcome to the show, Professor Jacka.
Thank you.
Let me start out with a very general question. How did you get interested in studying the relationship between diet and the brain?
It's a great question. I was doing my psychology undergraduate degree and I decided to do a PhD. And I'd done a bit of work looking at psychiatric epidemiology and the common mental disorders and how they related to aspects of physical health, such as cardiovascular disease and osteoporosis. And around that time, and this is in the early 2000s, there was this new field of research called psychoneuroimmunology, which I guess some of your listeners will know about, where we were really starting to understand that the health of the immune system played a role in the risk for mental health problems. And at about the same time, there were very interesting data coming out of UCLA in the field of neuroscience, so in animal experiments. And it hadn't been long before this that it had been established that parts of the brain actually grow new neurons over the life course. And that hadn't been recognised up until quite recently. And the group at UCLA, they were showing that they could manipulate this part of the brain that was very plastic called the hippocampus, and the proteins that help to, facilitate this brain plasticity by manipulating diet with an impact on cognition and animals' ability to learn and remember, because the hippocampus is very important for learning and memory, as well as mental health. So we already knew that diet was very important in immune functioning. And then this new evidence was suggesting that diet was also important in brain plasticity. So for those reasons, I thought it was likely that there would be a link between diet quality and what we call the common mental disorders, which is depression and anxiety disorders. And I felt that this was really important to study because we have a situation now, and this is based on the very large global burden of disease data, study data. Poor diet is now the leading cause of early death in men and the second leading cause in women across the globe. And that's because of major changes to the food industry, because of industrialization, globalization, big food. And at the same time, mental disorders, particularly unipolar depression and anxiety disorders, account for the leading global burden of disability. So if there's a link between those two leading causes of disease burden, then that's obviously very important for both prevention and treatment, public policy, clinical practice, etc.
It is always fascinating to me talking to people about this topic of diet in medical and psychiatric illness. I mean, I at most got 1 hour of education in diet. I'm not even sure if that's the case during medical school. And in psychiatry, it's completely absent.
Yes.
Even though now, we realize, and I think the medical system slowly acknowledges the important role. So you're really at the forefront of that movement to incorporate.
There's a big conversation happening in science and being driven by junior physicians, because the research shows that in the US and in the UK, about 75%, so 3/4 of junior physicians do not feel adequately trained or prepared to offer dietary or exercise advice to their patients. Now, given that chronic diseases that are informed by diet and lack of exercise are the leading causes of early death and disease burden across the globe, it's critical that medical practitioners are trained in lifestyle medicine. And at the moment, that's not happening. Tim Spector in the UK has been talking about this on Twitter this week, and it's something that urgently needs to change. It's what I call the elephant in the room. You know, it is, as I said, the leading cause of early death, and yet medical practitioners have almost no training in it.
And you know what makes it, it's considered to be a response to that of the medical system, that you know divisions hire dietitians who, in my opinion, are not really a substitute for a really well-trained physician who can explain the whole connection of diet with complex physiological processes like the immune system or like the metabolic system.
So many patients that won't be of interest, and for others it will be. I think what our data, so we've just recently, very recently published a meta-analysis looking at all of the research to date where diet has been changed, manipulated, and then the impact on depression or anxiety has been looked at as an outcome. And it shows that dietary change, dietary improvement can improve depression. Now, this is critical because this, as I said, is a leading cause of global disability. But also we've had no new treatments for depression for decades, no new pharmacological treatments. It seems to be a very cost-effective way of addressing depression. But what we show is that when the interventions are delivered by nutrition professionals, such as dietitians, this is when you get the greatest benefit. And this is because they are taught not just what to eat, you know, to tell patients what to eat or to not eat, but how to go about changing their diet. And that's the sticking point. That's the really difficult thing. In Australia, there's emerging new models of clinical practice in psychiatry, and we're involved in these. And as they're being set up, we're planning to evaluate them. But what the focus is here is on training nurse practitioners, because GPs generally don't have the time. Psychiatrists may have more time, but GPs certainly don't have the time to do the detailed counselling. So if you have nurse practitioners who are trained in lifestyle medicine, that is seen to be the way to go.
Yeah, so you already answered part of my next question, but which is, what is the current evidence for a relationship between diet and brain health in humans? As usual, in this area, you know, we have a lot of preclinical mouse studies, like mice fed the high fat diet, often not really translatable to a human condition. And then we have large scale epidemiological studies and meta-analysis, as you said. But what about intervention studies, longitudinal studies that are specifically testing a dietary intervention on brain health, on a brain disorder in humans?
So what we have, as you've alluded to, is a very large amount now of observational data. So, you know, of course, this means we're collecting data from large samples of people on their diet, on their mental health, and on many other factors that could explain a link between the two, things such as education, income, body weight, other health behaviours, etc. And you know, the field is relatively young. My PhD was published in early 2010, and that was the first study to look at this, you know, in terms of clinically diagnosed common mental disorders. But since that time, we've had many studies across the world. So this is in places as diverse as Norway and Spain and Japan and the US and UK, Australia, many studies confirming that diet quality is related to the prevalence of and the risk for depression in particular. And we now have several meta-analyses that confirm this. It seems to be independent of other potentially explanatory factors such as education, income, etc. The prospective studies try as much as possible to rule out reverse causality, so people changing their diet as a result of their mental health. And so the data there are very consistent. We also have a less large, but certainly fairly robust body of literature linking this relationship in young people as well, children and adolescents. And of course, this is critical because half of all mental disorders start before the age of 14. Now, if we think about the risk factors, established risk factors for mental disorders, they're things such as family history, early life trauma, life stress, economic disadvantage. These are risk factors that are very difficult to modify. They're complex, difficult to modify. But we now know that diet is very clearly linked to the risk for mental disorders in young people, as is exercise and physical activity. And there's also data on smoking as well. Now, these are all three lifestyle factors that are modifiable. So if we want to think about prevention, we can think about targeting these. We're also having emerging data from human studies that is backing up what we see in the animal studies. And that's around, the role of diet during pregnancy on a range of outcomes relevant to mental health in offspring. So that's things such as inflammation, neuroinflammation, mitochondrial function, neurotransmitter systems, etc. But we also have data linking the quality of people's diets to the size of their hippocampus. Now, we published the first study on this in 2015, but this was replicated in two far larger studies last year, showing that diet quality is very clearly linked to the size of the hippocampus. Now, this, of course, is very important across the age range because of the hippocampus's importance in learning and memory. But in older people, as we age, our hippocampus shrinks, and of course we have, we start to lose our car keys and forget where things are. And this seems to be linked to this shrinkage in the hippocampus. And the fact that diet, and it's not a small effect size either, it's a pretty large effect size. Diet quality is very clearly linked to brain health in that regard is really critical. But as I alluded to, we now have data at the meta-analytic level that if you change diet, you change depression. And of course, that's the key piece of the puzzle that you need to demonstrate causality. Now, we ran our SMILES trial in 2017. It was a small trial, but it sought to try and answer the question, if someone has clinical depression and you help them to improve their diet, does it improve their depression? We randomly assigned people with major depression to receive either a dietary support with a clinical dietitian or social support using a befriending protocol, which we already know is helpful for depression. And, over a 3-month period, people got one of those two interventions. Now, those in the dietary group were supported by the dietitian to make improvements to their diet, to reduce their intake of junk and processed food, fizzy drinks, sweets, cakes, donuts, chips, pies, all of those sorts of things, but also to increase their vegetables and fruits, whole grain cereals, nuts and seeds, legumes, olive oil, fish, the foods that we know are really fundamental to good health. And what we showed was that the people who got the dietary support, A, they were able to improve their diet. B, they had a really marked drop in symptoms, so a very large effect size, but of course it's a small study, so we have to be cautious in our interpretation. But very importantly, I think there's a few points that came out of that trial. One was that the degree of dietary change correlated very closely with the degree of improvement in depression. Second was that the diet we were advocating was actually cheaper than the diet people were eating when they came into the study. So putting to bed this idea that it has to be expensive to eat a healthy diet. And third, and I think this is the most important, we did a detailed economic evaluation that showed that this appeared to be a highly cost-effective way to treat depression. The people in the diet support group, there was a cost savings of about $3,000 per participant because they lost less time out of role and they saw health professionals less often. Now, 6 or 8 months after our study was published, colleagues in South Australia published a similar study, but it was in a group-based setting and it had a much larger sample size. Ours, we'd failed to reach our target recruitment, so we were underpowered. Theirs had adequate power and they showed very, very similar to us, including the correlation between dietary change and mental health change and the cost effectiveness data. Now, the meta-analysis I referred to, what we've done is we've looked through the literature at many, many studies where they've manipulated diet and measured mental health outcomes, depression and anxiety outcomes. Now, nearly all of those, except for our SMILES study and the Healthy Med study, were done in people without depression. So they either had, you know, a metabolic disorder or maybe cancer or the general population, what have you. So we still clearly need more data from clinical trials to really confirm this and to understand what the effect sizes are, and of course to really get at what sort of diets are best for people. I mean, so far all the evidence is pointing to a Mediterranean style diet, but certainly the observational literature suggests that traditional diets around the world are associated with much better mental health.
So traditional diets in Asia and Europe would generally have a higher proportion of plant-based foods. I think that's kind of one of the common denominators. Would you agree?
Where we're at with the evidence so far is that diet, exercise and smoking cessation all seem to result in benefits to mental health. And given we are starting to see that this is a very cost-effective approach to treating depression, because of course, if you think about depression, people with depression have very commonly comorbid chronic physical diseases such as heart disease or metabolic disorders or diabetes, etc. And those things are also risk factors for depression. So if you take a lifestyle medicine approach to treating depression, you're going to have benefit to the whole person. You're going to have benefit to those comorbidities. So it seems to me that it's just common sense.
Yeah, absolutely. Do you want to, I have a couple of questions to your own study, which I always show in all of my presentations. So the role of the dietitian, did the dietitian visit patients or did the patients come into the hospital and spend time?
The patients came to the study centre first weekly at first and then fortnightly. And they were supported to make their own goals, you know, and this is what a dietitian does, or a good dietitian is trained to do, is to help people to make their own goals and make, you know, for the coming week or the coming fortnight, and some guidance on how they might achieve those goals. So they might be things like swapping over from using white bread or white pasta to using whole grain cereals, and to increasing the diversity of whole grain cereals, to increasing the numbers of vegetables and the diversity of vegetables in the diet, to increasing fruit intake, to start to eat the legumes, so chickpeas, lentils, beans, those sorts of things, get those in a few times a week, to have fish, to start to use olive oil instead of, you know, butter and margarine and those sorts of things. So these changes they made gradually over that period. And the wonderful thing is that I think there was a lot of skepticism about the ability of people with a disorder such as depression, where you often get fatigue and, you know, a loss of interest and energy, whether they would be able to make these changes. But actually what we found, and this has been reported more commonly now, is that people love this because it's something that they can do for themselves. You know, for many people, they've got stuff going on in their lives, very stressful things that they can't control, but this is something they have control over. And very importantly, we made it very achievable for people. You know, there's no need to go and cook complex recipes. You can use tinned beans, you can use dried beans, you can use frozen vegetables, you can use tinned fish. You know, we gave people instructions that were exceedingly simple to manage. And there's actually one person in the US, or there's a couple of people in the US, psychiatrists, who use this approach in clinical practice. One is Drew Ramsey at Columbia in New York, and the other is Dr. Emily Deans in Boston. And they're both marvellous in the way that they approach patients. It's very simple. It's starting the conversation. What do you like to eat? What don't you like to eat? What do you normally have for breakfast, lunch, dinner, snacks? And then working with them to say, okay, so how do we swap out this sort of food, which we know is not doing you any good, to this sort of food, which we think will do you some good, in a way that it's affordable and achievable. So that's the sort of training I think physicians need, not complicated biochemistry-based information about nutrition. They just need this really simple, how do you help patients with motivational interviewing to make some really basic fundamental changes to their lifestyle behaviours.
Mm-hmm. I don't know if you or others that work in this area have looked at the possible role of the gut microbes in these health benefits, in dietary health benefits on the brain.
And this is, of course, a real focus for us. So I set up the Food Mood Centre sort of around the beginning of 2017, so not that long ago. And our team has grown very rapidly from 3 to more than 20 people now. And we're running more than 20 projects, I think 22 at the last count. And I think 20 of those at least, if not 21, are involving the gut microbiome. Because we think that this is a key pathway by which nutrition might affect mental health. Unfortunately, our SMILES trial and the Healthy Med trial sort of happened. They predated our knowledge about the gut microbiome. And also, of course, research is slow. So the research projects we've been running, the first data from those from our group will start to be published this year. And that's from an intervention that we did in pregnant women through the Royal Children's Hospital in Australia, where we know that pregnant women, like the rest of the population, have a very poor diet. We know that the early life microbiome seems to be linked to brain development and the development of the immune system. We wanted to see whether we could, A, get women who are pregnant to improve their dietary intake, and B, whether that would have an impact on the microbiome profile of the infants after birth. So we've finished that study now. We've got some very, very interesting data and results that will be published later on in the year. But as I said, we're running approximately 20 projects where we're collecting data on the microbiome. So over the next 5 years, we'll have a huge number of data, looking at this three-way relationship between diet, the microbiome, and mental and brain health.
What role, if any, do you think that probiotics, supplements, so-called psychobiotics, play in the therapeutic effect of diet on the brain? Or do you think the diet itself outweighs the benefits that you might get from such supplements?
Look, I think the Deakin study in mania is the most convincing evidence as far as I'm concerned. That was a randomized controlled trial, people with bipolar disorder who'd been hospitalized with mania. After they got out of hospital, they were given randomly assigned to get either probiotics or placebo. And then the researchers measured the amount of time until they went back into hospital with another episode of mania. And they found that that was substantially reduced in the ones who got the probiotics. So that to me is the best evidence to date that it might be useful to take a probiotic supplement. Our thinking though is that generally the probiotic supplements are transitory, which doesn't mean that they don't do anything, but I think that dietary change is a much more profound, long-lasting way of positively impacting the gut microbiota. And we know that you can change the health of your gut within days by changing your diet. And we know that diet, based on the current evidence, diet's the most important factor affecting the microbiome, and that to improve our gut microbiota and the health of our gut bacteria and gut lining and all of the things that are influenced by that, including the immune system, metabolism, body weight, and the brain, you need a lot of plant fibre and you need a lot of diversity. So that again comes back to this Mediterranean style diet with lots of different types of plant foods, whole grain cereals, legumes, nuts, seeds, etc., healthy fats. And we're also very interested in the possible role of fermented foods and are quite keen to actually trial some of these because, again, a truly fermented product, especially with a traditional fermenting process, has just so many metabolites as well as the actual bacteria themselves that we think there's, evidence there that suggests that they may be useful in tackling, say, depression or anxiety. But obviously that needs to be tested in randomized controlled trial conditions.
Yeah, I mean, I couldn't agree more with what you said. We had this idea once to collaborate with Korean investigators because, as you know, in Korea, every meal yeah, it consists of, 20 little plates with different fermented fish and vegetables and seafood. And people there eat this from childhood on, this type of fermented food. It's just difficult in a place like Korea where mental disorders are so stigmatized to get accurate numbers.
I know, it's very difficult. We had the same idea, and we're very interested to look at autism because, of course, in any country, even that with a very healthy traditional diet like Korea or Japan, there is still a real variation in diet quality, and some people will be eating a much more traditional diet with lots of fermented foods, and others will have transitioned to a much more Western diet with, many more packaged and junk foods. So within populations, you can actually look, and I believe that there was a paper just published in the last couple of weeks from Korea showing that the intake of fermented foods was inversely associated with depression. But as you say, comparing across countries is exceedingly difficult because the way that depression or mental health is thought about or understood or measured is very different across countries. So making comparisons is difficult. But within countries, I think looking at the variation in diet quality and linking that to your health outcome, there's still a lot to be gained by doing that.
Yeah. Based on your experience with the SMILE study and these encouraging results and then confirmation in follow-up studies, do you think there's room for diet alone treatment of mild depression or anxiety? So not a DSM-4 diagnosis, but positive scoring on a questionnaire like they had. And is there any evidence to support such an approach? So you would not start out with an antidepressant or an anxiolytic, but you would start out with a dietary recommendation and coaching.
I think so. I mean, certainly in our study, in the SMILE study and in the Healthy Med study, most of the participants were on other forms of treatment, with antidepressants or psychotherapy or both. So certainly as an adjunctive treatment, we can say it seems to work very well. Our meta-analysis looked at, we had about 16 randomized controlled trials. And as I said, only one of those actually, which was our SMILE study, met the criteria for inclusion, where we'd actually measured this effect in people with depression. And in all the other samples, they were largely people who didn't have clinical depression. And we still saw a real substantial improvement in depressive symptoms by taking a dietary approach. So I think the answer to your question is yes. We need to directly measure it in people with subsyndromal symptoms. But you would be interested and maybe pleased to know that in Australia and New Zealand, the 2015 updated clinical guidelines for the treatment of mood disorders by the Royal Australian New Zealand College of Psychiatrists actually has diet, exercise, smoking cessation, and, addressing any substances as the first thing that you do before you do anything else.
No, this is really exciting. I think it will be some time, probably the lobby of the pharmaceutical industry is probably trying to prevent this from happening in the US, but that's certainly very encouraging. And I think sooner or later.
It doesn't mean that it's happening though, because of course you make guidelines. It doesn't mean, and particularly if people are not trained to deliver lifestyle medicine and they don't know how to do that, then they are still going to default to an antidepressant or some other form of treatment. But I do think it's really encouraging that the guidelines are there, and they suggest this as step 0, first thing that you do. Now it's about getting it into clinical practice by, I guess, giving patients the information so that they can start to ask their practitioner for lifestyle support, and for governments and policymakers to start to recognise that it's much more cost effective to do this than it is, certainly in Australia. The Better Access Scheme, because we have a universal healthcare, that supports people with a mental health condition to see a psychologist several times a year, that's ended up costing a lot of money because I don't think the government recognised just what a great need there was there. And so the fact that both our study and the Healthy Med study showed that it was highly cost effective to take a dietary approach to treatment, hopefully policymakers are looking at this, and the people who make the clinical guidelines, and thinking, okay, well, how can we leverage on this to change what we're doing to save the public purse a lot of money, as well as to save, have the health benefits and save people from suffering.
Yeah, that's encouraging. I think there's clearly going to be a change driven by multiple forces, actually. Cost and the economics of it, probably one of the most important ones. Let me ask you.
I have to say, it's really why I wrote my book, was to get this information out there to the lay public so that they can start to push for change themselves. Because I think that that's the only way that you get change happening.
Yes. Yeah. Talking about your book, what is the main take-home message from your book? So anybody who's interested after listening to our conversation wants to get your book and order it on Amazon, what's the main take-home message that you convey in that book?
That what you eat or what you feed your family is directly relevant to their mental and brain health across the life course. So this means children's mental health and their ability to learn, adults right through the age range, and then at older age, as we go towards a risk for dementia, etc. That diet seems to be really important in both preventing and potentially treating. Certainly depression at this stage, we know that's where the bulk of the data are. That's the key message. The second key message is that in common with what Dr. Margaret Chan, who's the head of the WHO, said at the big emergency meeting with the UN in 2011, because of the food environment and the way it's changed and the impact it's having on our health across the globe, it's going to cost the global community approximately $30 trillion by 2030. And that's, of course, without taking into account the huge cost of mental disorders and dementia, etc. And that only the heads of government really have the power to address the activities of big food, which is what is driving this. So a lot of the book talks about, well, not a lot of the book, but a bit of the book talks about the issue of the food environment, gives some really nice concrete examples, talks about the disaster that we're facing. Something like 60% of children alive today in the US will be clinically obese by the time they're 35. And we know that that has huge implications for the mental and physical health of the next generation of their children. We have to start to reverse the detrimental changes to the food environment to support people to eat foods that have not been interfered with, whole foods. So Michael Pollan said it best, really. It's, eat real foods, not too much, mostly plants. It doesn't need to be complex. But, of course, big food doesn't like that message.
Yeah, so really a exciting scope of topics for your book. So anybody who wants to read more about this, highly recommend Brain Changer, the Good Mental Health Diet. Last final question. What kind of diet do you eat yourself?
Oh, I guess it's a Mediterranean style diet. I love vegetables and fruits. I eat a lot of beans, different sorts of beans. I eat different types of whole grains. I love fish. I use a lot of olive oil. I love yogurt. I make my own kefir. I try and get as much variety into my diet as I can. I've got a small herb garden and I try and get lots of different herbs into my diet. So diversity is good. And I very rarely eat, I guess what you would call, in Australia, they're called discretionary foods. I had a bit of Norwegian chocolate last night because I've just come back from Norway, but that would be a once a week thing. Or I might on a Friday night have a small amount of, a sort of a gelati or something like that as a treat. But generally I just don't eat those sorts of foods. I don't enjoy them. And I find, I'm very, very super busy. So I'm not spending a lot of time cooking generally, but I know how to use shortcuts to eat really well, quickly and in a way that's not particularly expensive.
Well, thank you, Professor Jacka, for a really enlightening conversation. I hope we can continue this live at some point in the near future. Certainly, it seems in many areas we're operating on the same wavelength, and thinking along the same lines and probably have the same ambitions to change the food culture around the world in order to promote health. Thank you very much.
It's lovely to talk to you, Emmerin, and I'm sure I'll see you around the traps this year at some point.
Absolutely. Thanks a lot, Felice. It was great.
Enjoy your evening. Okay. I'll see you again.
Bye-bye.
Bye-bye.